Thanks for joining us. I'm Sheila Eswaran. I'm one of the hepatologists at Rush. And with the support of American Liver Foundation, we've been doing the HCC Hospitals of Chicago Consortium for the past few years. Quarterly, we get together to talk about HCC cases, bring in different subspecialties that are involved in HCC, bring in different institutions to share ideas and talk about how we do things similarly and differently and learn from each other. So this is really an interactive discussion. So thank you so much for the American Liver Foundation for allowing us to do this using their platform. Just wanted to let you know that we're recording this so that future generations can hear the presentation and the discussion. So just so you know, it is being recorded. Thank you so much to our sponsors. We really can't do this without you. AbbVie, Genentech, and Salix, thanks for your support for this program and all the other American Liver Foundation programs. You all know, and please feel free to take a screenshot of all the different ways that American Liver Foundation can touch providers and patients. There's a lot of different options in terms of how to share information, including YouTube, Facebook, Instagram, helpline, call, text, website. You can see those are listed there. And also keep on your calendar, next Thursday is the American Liver Foundation Michigan academic debates. There are two topics, Ascension Providence versus Henry Ford, and University of Michigan versus Cleveland. The debates are about non-selective beta blockers and COVID-19 for transplant patients. So it's a virtual meeting, obviously. So if you want to log in and root for your alma mater, Justin, University of Michigan, so you can log in there. I'm sure you're going to attend.
Another Michigan-Ohio battle, right?
It's a Michigan-Ohio battle. Another one, yes. So tonight we're going to start off with a presentation by Dr. Lucia Rivera Matos. She's our liver transplant hepatology fellow at Rush. And she will be discussing a clinical case and a journal article focused on the multidisciplinary approach to liver cancer. As we all know, it's very important to have a multidisciplinary approach. And so we're hoping that it's a discussion and a dialogue. So please feel free to interrupt, chime in, and ask questions. Lucia has been a great addition to our team. She just matched in gastroenterology yesterday, and we are so proud of her. She'll be finishing off the year, of course, and then on to Louisville to do bigger and better things. So Lucia, congratulations, and thank you so much for presenting today.
Thank you so much, Dr. Eswaran. Thank you all for being here, for having me here. I'm going to start by sharing my screen. Okay, let's see. Sorry, give me a second. Okay. All right, so as Dr. Eswaran just said, my name is Lucia Rivera Matos, and I am the Transplant Hepatology Fellow at Rush University Medical Center right now. And I will be talking today about the benefits of multidisciplinary care in regards to HCC. So I'm going to start with that case presentation. Please feel free to interrupt me if you have any questions. So it's about a 69-year-old Hispanic man that presents for evaluation of a recently diagnosed HCV infection. And he had no known liver disease prior to this point. His medical history was notable for hyperlipidemia, hypertension, and genital herpes. He denied any surgical history, and his social history was notable for having approximately 7 wine glasses, during the weekend for 5 years now, and he denied any tobacco or illicit drug use. In terms of his home medications, so he was on olmesartan 20 daily, an iron daily, vitamin D3, and then Lasix 20 milligrams BID just for his hypertension. The lab work that we had available by the time he came to see us for the first time included a white blood cell count of 3.7. His hemoglobin was 13, and he was thrombocytopenic 294. His liver panel was notable for elevated T-bili of 1.6, a normal alkaline phosphatase of 82, and then his AST and ALT were both abnormal. His AST was 123, and his ALT was 97. Otherwise, his sodium was normal, potassium was 4.5, creatinine was also within normal ranges. His INR was 1.16, and then at that time, he had a HCV RNA quant of approximately 3.6 million. So given his laboratory findings that were concerning for him having underlying liver disease, given the abnormal liver function test platelets, we got ultrasound abdomen with elastography, and this test had an incidental finding of 3 hepatic lesions. So the measurements were as follows. They were 1.8 times 1.5 times 1 centimeter. The second one was 3.4 times 3.9 times 4.2 centimeters. And then the third one was 5.6 times 7.1 times 6.8 centimeters. And then besides this, the elastography part of the study was notable for liver cirrhosis with a KPA of 14.11. So given the findings of these 3 lesions that were concerning for hepatocellular carcinoma, we ordered further workup, which included a DCP that was elevated to 242, AFP that was 30.3, and then AFP L3 that was 17.1. Sorry about that. So our next step at this point was getting a CT triple face to further characterize these 3 lesions that we saw in ultrasound. And at this point is when we, started facing challenges with his care. So I made this slide just to be able to give you all a perspective on the timeline, which is what we will focus on from now on, as we're going to focus on, the benefits of the multidisciplinary approach to HCC. So within 1 month of his visit, we had so far gotten the ultrasound abdomen with elastography that I mentioned earlier. We ordered the CT triple face, however, was still not done. And we also placed a med oncology consult for him. By the 2nd month after his first visit, he was unable to get the CT triple face because his imaging, his insurance unfortunately did not cover any advanced imaging. That's what we were told by our care coordinators. And unfortunately, the med onc appointment was not scheduled yet. Why these appointments were not scheduled, for us, it's unclear, but he did have, he was mainly Spanish speaking. He doesn't speak English to any degree. So I think that could probably have played a role in that. And then, so what we got from the insurance was that his imaging studies would only be covered if they were done during ER visits. However, not that being intentional, by 3 months after his initial visit, he presented to an outside hospital ER with chest and abdominal pain. At that time, they did a CT chest without contrast, and they also did an MRI, MRCP with and without contrast, which I will show you in a second. So his CT chest showed actually focal lytic lucencies in at least the T2 and T10 vertebral bodies, which were concerning for metastatic lesions. And then the MRI, MRCP just mainly showed what we knew already, which were the 3 lesions. The measurement of one was, the maximum was 7.6, the other 3.5, and then the third lesion's maximum measurement was 1.6. So at this point, we're at 3 months from his initial visit, and we discussed the findings we had so far, and we evaluated the imaging disc actually in our tumor board discussion. And the decision was to obtain MRI of the cervical, thoracic, and lumbar spine to further evaluate for metastatic disease. And at this point, at 3 months, he still had not been seen by med oncology because of the issues with scheduling. And unfortunately, we continue to have the insurance cover issues. So in order for him to get the MRI of his spine, it was also very challenging. So thankfully, with the help of his family members, they were able to switch insurance. So we were finally able to get the MRI. And surprisingly, it showed that there were no focal suspicious malformations either in the cervical, thoracic, or lumbar spine. So at this point, as you all know, our view into his HCC changes just because if he had metastatic disease, his classification would be very different and hence the treatment. So at this point today, the same day that we saw him after he got the MRI, we sent him to interventional radiology, which he was fortunately able to see that same day. And he's now status post 190. So finishing my case presentation, the main points that I want to bring to all of your attention is all the challenges that we faced with his care. So these included the language barrier, which could have had a part in his scheduling issues, the evaluation to treatment time, which for him was approximately 6 months. Also the issues from a social standpoint, which included health insurance coverage problems, which definitely limited this patient's workup and at least the time frame in which it was done. Outside hospital visits also were a challenge to us just because he would obtain imaging that he came to our clinic and then we unfortunately did not have the disc with him. So we'd have to request that, and that's additional treatment, additional time that we're losing that we could be spending in his evaluation for treatment of his HCC. And then the biggest question is how could we have modified his course? As many of you probably know, at Rush, we use a sequential cancer care, which is basically we just see the patients on our own and then we refer them. We do have a tumor board meeting every Friday in which we discuss the imaging with transplant surgery and also with interventional radiology and diagnostic radiology. However, now I'm going to discuss a study that evaluates the effectiveness of a multidisciplinary approach.
And before you do, Lucia, that's a great presentation. I think it highlights a lot of the challenges that we have, at least in Rush, in our approach. But I'm wondering if this is a institutional problem, or are there other institutions in the city that have these same issues? This is, I would say that this is a less common scenario where things were dragged on far too long, and generally things run more smoothly. But I'm wondering from, I think I see UIC, Northwestern, and Loyola on the line. I'm super interested in hearing just briefly, would this be a common scenario for you, or how do things run at your institutions?
So I can speak to UIC's experience. I would say that I don't want to say this is common, but certainly I've had several patients that fall into this category due to kind of language, socioeconomic barriers that prohibit kind of timely diagnosis, and then insurance barriers that prevent us from getting imaging that we need. And where it has to be one scenario that's really frustrating is, because of an HMO, it's mandated that it be done at another hospital. And then, as Lucia was describing, trying to get the discs to review to figure out what the treatment plan is going to be. And those delays in care add up much faster than you'd like them to. So I wouldn't say it's common, but we definitely have this issue with several patients as well.
And Adam, at UIC, do you have a central multidisciplinary clinic, or is it sequential like Rush?
It's sequential as well. We have, a tumor board meeting weekly as well. And as Lucia described, IR will usually see the patient same day, but in order to get somebody into oncology, it's going to be sequential.
Thank you. And Mark or Riyadh, I'm not sure if you can chime in either. your experiences?
Yeah, maybe I can say this is Riyadh. Sorry, I'm putting the kids to sleep too. So, yeah, so we have the same sorts of issues. We too are sequential, although we're working on a model now to see everybody with transplant and med-onc and IR in one day. You know, that Mayo model. It's kind of tough to do that, but we're trying to do that. But we have the same challenges, and I would say, Sheila, that I think the issues and the barriers that insurance carriers impose on us are underappreciated, underestimated. I think they are much more frequent than we all talk about or recognize. And it's not uncommon that, for whatever reason, your treatment is delayed by weeks and sometimes months. It's very disappointing. It's not supposed to be like that in a quote private environment, but it's definitely a big issue.
Yeah, and it takes so many resources to get around that the hospitals then have to recognize that too.
That's correct.
And Mark, are you guys at Loyola? I think you're sequential, also see patients separately, and then but have a tumor board once a week. That's the Loyola model from my understanding. And then I'm not sure about University of Chicago. Anjana was going to try to join, but she's on service. So so I think, in the ideal situation, things run smoothly, but Lucia brings up this case to highlight the challenges that we have. And then I'll let you go ahead and talk about the journal article.
Sheila, is Mark here. Can you hear me?
Yes, thank you, Mark.
Yeah, I think I got some audio working. I would just add a couple things to Riyadh's comments. The insurance has been a big hurdle for us, a lot of resources into that, in my realm, particularly the radioembolization. We have spent years trying to change the paradigm where we can get insurance approval for a mapping study for radioembolization, but then we have to go through the same process again for the actual treatment, as opposed to getting approval for the whole treatment paradigm in one setting. Lots of resources go into that. At Loyola, in terms of the multidisciplinary paradigm, we do have this sequential paradigm. Care is primarily quarterbacked by the hepatology service, but oncology is a secondary referral. At our Veterans Hospital, maybe it's a touch more organized in that oncology has a presence at our multidisciplinary conference. So decisions are made with a group setting with oncology, IR, surgery, and hepatology present at the same table.
And with respects to the Y90 coverage, was that an issue when it wasn't? And you guys know the details, but it recently was. It previously was done compassionate use or off label, and now it's on label. Is that been easier now to get through insurance, or is that still an issue?
Yeah, it was through an IRB HDE human device exemption pathway, and it has gotten full approval now. So I think it has gotten easier with that. That's a good point. Yeah,
maybe. And then Riyadh at Northwestern, is med-onc there for your multidisciplinary tumor board present?
Yeah, they sure are. We have presence from either Aparna or Mary Mulcahy, so they will come. And again, we also try to go to their clinics as well. But yes, we do have med-onc. The only group that we don't have representation with is rad-onc. There's no rad-onc.
Yeah, we have rad-onc every week, but med-onc is a little bit stretched thin currently at Rush.
The other thing I wanted to highlight, Sheila, because I think you brought it up a few times, but you implied this, is we have all the data that we're used to with IMBRAVE and all these studies, that are based on overall survival from randomization in the ideal scenario. But in many of these cases, like your patient, he's lost 3 months of potential benefit from whatever he's going to receive. And any sort of post hoc analysis you would do on that patient, you're starting your OS from the time of treatment. You've lost 3 months, and it serves a shame. And that's why sometimes some of these OSs are lower than what you expect, but that's because of the realities of getting patients on treatment.
Yeah, yeah. Definitely the process is not necessarily captured in the clinical trials, because in a clinical trial, it's the best case scenario when you have all the resources to navigate and to move the patients forward to the best possible outcome. But in the real world, we don't necessarily have that.
Right. That's right. And you lose months by that. Yep.
I can't remember the numbers from the ultrasound, but was this patient within transplant criteria based on the ultrasound tumor sizes?
No, he wasn't. It was 7.1 was the largest.
Already outside. All right.
Yeah. But yeah, that seems to be the best and quickest pathway, because IR or hepatology and transplant work so closely together. We can get him into the transplant clinic the following week.
Riyadh, I was at an ultrasound conference a year or two ago where they were talking about using triple phase ultrasound contrast in Canada, where they don't have many MRIs. In Canada, they think they can approach the diagnostic quality of MRI with ultrasound. And I'm aware there are some people who are trying to work on LIRAD's criteria for ultrasound. Do you guys ever consider substituting ultrasound contrast for MRI? Have you ever come across that paradigm?
Not really, Mark. To talk about something that would probably be really operator dependent. We've done some little work with some bubble studies with post-treatment in scenarios where we can't give contrast or whatever, but I can't envision that ever sort of replacing at least a very standardized and objective cross-sectional tool. But no, I know that the Canadians have done some of that stuff basically to do fewer MRs, but no, I have not encountered that.
Yeah, okay.
We have some experience at Rush with contrast enhanced ultrasound, simply because I think the cardiologists are really familiar with the contrast. And so a couple of years ago, or maybe in the past 3 or 4 years, we've had that as an option for people that can't have an MRI or CT. So we do have we have one diagnostic radiologist and one technician that is very familiar with that option. So we sometimes do offer that.
Sheila, do you do it for trying to diagnose, characterize a lesion, the triple phase MRI or CT where there's arterial phase enhancement and then washout? Do you use that in lieu of CT or MRI on occasion?
I like you alluded to, the LIRAD's criteria for CEUS, and I think that's the purpose of using it as an alternative to characterize and diagnose HCC. If they can't get a CT for one reason, creatinine, can't get an MRI because of hardware, we might offer that, and then look to see if there are suspicious characteristics, high LIRADs criteria, and then probably end up biopsying anyways, but to confirm it. But yeah.
Interesting. Yeah, it'd be.
Mary Chen is the diagnostic radiologist that does them at Rush.
We have John Hiblin, who came from Rush.
That's right.
Does them for us. Yeah.
Okay, great conversation. Lucia, go ahead. Thank you.
All right, so this is the case, the study that I'm going to be presenting. The title is Multidisciplinary Approach is Associated with Improved Survival of Hepatocellular Carcinoma Patients. So as a general background, which we're all very familiar with, HCC is the third most common cause of cancer mortality worldwide. And it usually arises in the setting of decreased liver function. This disease also has a very complex prognosis and management. And the management specifically is most challenging just because the physicians should not only assess the risk of benefits of the treatment on the tumor, but also on the entire patient's clinical history, comorbidities, and also their liver function. Something else that also makes this very complicated is that a single provider usually cannot adequately meet all the patient's care needs, even though we all always have the best intentions to take care of them. So a multidisciplinary approach has been recommended as a strategy that can help cope with escalating complexity in these cases, not only actually in hepatocellular carcinoma, but also in malignancies. So the management of HCC requires medical expertise in several specialties, which are all included here. As we know, interventional and body radiologist, medical oncologist and pathologist, primary care, palliative and hospice, gastroenterologist, hepatologist, and then a liver transplant program with hepatobiliary surgery. And something that was left out of this diagram are also care coordinators, which, as we know, have an extremely important role in all of these patients' care, specifically in all the socioeconomic difficulties.
And let me ask the group too, then, looking at this diagram, you know, do you guys have a palliative care connection with your multidisciplinary tumor boards? Do you have a presence or a representation at your tumor board for palliative care or nutrition, for that matter? Or
Yeah, I would say for Loyola, I can't really comment on that. Our conference presence is mainly focused on oncology management. So I think those things are part of the hepatology realm, but not part of our decision-making about tumors treatment.
yeah, at Rush, they're not part of our tumor board, and it would require a referral to the palliative care team separately. We have a separate GI cancer clinic, multidisciplinary clinic for luminal cancers, pancreatic cancers, esophageal cancers, cholangiocarcinomas, and they have a more robust, obviously, oncology presence and palliative care presence, representation, and genetic counseling representation appropriately, but it's something that's definitely lacking on the HCC side. So I didn't know if that was just a institutional thing or more of a more common in other situations, also institutions.
All right, so based on this study, what they defined as a multidisciplinary tumor board was basically an alliance of all medical and healthcare professionals related to a specific tumor disease, whose approach to cancer is guided by their willingness to agree on evidence-based clinical decisions when able, of course, and to coordinate the delivery of care at all stages of the process of the patient's malignancy. It has been suggested as a tool for complex cases of HCC. And in several studies, as someone mentioned earlier, have suggested that multidisciplinary tumor board might improve survival. Another thing is that it has a high cost for institutions that makes the difference of the large academic centers that we're discussing here. Some institutions don't have access to all of these medical specialties, including radiology, oncology, interventional radiology. So it can have a high cost for smaller institutions or hospitals in the community. So in terms of the study design, this was a retrospective cohort study based on a prospective HCC registry at Samsung Medical Center in South Korea. So they identified a total of 6,600 patients with treatment naive, newly diagnosed HCC. And of these, 11.1%, which are 738 patients out of the total cohort, had multidisciplinary care management. So this multidisciplinary meeting consisted of an 1 hour meeting every week with a maximum amount of 15 cases. So this was comprised of all the multidisciplinary specialties that we discussed in the previous slide. And the decision for the patient to be presented on these meetings was mainly in the physician in charge of the patient, which was usually the hepatologist, which are the ones to which the patient is referred for the first time. And these consisted in case representation, image review, and then an open discussion. In terms of the method, so the primary outcome for this was overall survival, which is abbreviated in the rest on the PowerPoint as OS. And the survival time was defined from the date of diagnosis until the date of death or last hospital visit. So the exposure, as we know, was the MDT management. And for the confounders, they used the following variables, which included the age of diagnosis, sex, year of diagnosis, the etiology, the CP class, the BCLC stage, AFP. And they also used the PIVKA2, which at least at Rush, we don't have to use that, but they included this in the study, and also the initial treatment modality. Other classifications that they used was the ALBI, which was an albumin bilirubin score. They calculated this with an equation just only to have a representation of the liver function estimate. And they, based on the values that they got, they predefined 3 subgroups. And the other classifications that they used were if the patient received BCLC guideline recommended therapy, which, as we know, or at least at this time in 2019, when the study was published, the stage 0 or A would be resection, ablation, or liver transplant. For stage B, TACE. For stage C, sorafenib, and then for D, the best supportive care.
And Lucia, the PIVCA is the DCP, so we do use that.
Oh, so it's exactly the same. Okay.
Mm-hmm.
So in terms of the method, so they use an exactly matched cohort which consisted of 698 patients specifically. They were matched in a 1:1 ratio, and they balanced the characteristics that are mentioned here between the groups. So they used age divided in 4 subgroups, which was less than 50, 50 to 59, 60 to 69, and then more than 70. The year of diagnosis, which was 2005 to 2007, 2008 to 2010, and then 2011 to 2013. For etiology, they divided mainly into subgroups, which were hepatitis B related and others, just because in South Korea, that's the most common cause of HCC, which we will get to when we discuss the limitations of the study. And then they also matched them for BCLC stage and for the serum AFP levels, which they used a cutoff of more than 200 or less than 200. And for the statistical analysis, they initially did a variable comparison between the 2 groups. They also evaluated the difference in treatment choice, the difference in overall survival, which was done with the Kaplan-Meier method. And then they also evaluated the hazard ratio for mortality by MDT management. And this was done in an unadjusted and also adjusted manner. And now I will present the results. So as we can see in this table, I know it's very big and difficult to get an eye on, but when the variable comparison was done, they noticed that the patients that underwent multidisciplinary approach were older. They also had a male predominance. They had more preserved liver function, less advanced tumor stage, lower AFP levels, and also lower DCP levels. In terms of the difference in treatment choice, this was actually interesting. So the patients who got resection, ablation, or liver transplant as first-line treatment were very similar in the 2 groups, that being the MDT group and the patient that was not managed in a multidisciplinary approach. However, when comparing the group to the one that did not receive it, patients in the multidisciplinary approach, more of them received TACE or other treatment, but less of them received the best supportive care. No difference was noted in the proportion of patients that were actually receiving the BCLC guideline recommended treatment before stratification. However, when they stratified it according to tumor stage, less patients received BCLC guideline recommended treatment in several stages, specifically in stage 0, stage A, and stage C. And this was all in the multidisciplinary group. However, in this same group, patients with BCLC stage B did receive more BCLC guideline recommended treatment. In terms of the overall survival, so the survival rate was significantly higher in patients that were managed via the multidisciplinary approach. And we can see in here the statistics, 71.2% versus 49.4%. And the hazard ratio was 0.47. In here, we see the survival curves, which mainly explain what we were discussing in the last slide. So these are the Kaplan-Meier curves. We can see on the top figure, the patients that were not adjusted. And then on the bottom figure, we can see the ones that were adjusted. But we can see that in both of them, there was statistical significance with comparing the overall survival when they were followed up after the years. So this table I found that was very, very interesting. It describes what factors they noted that were associated with OS overall. So as we can see in here, so these are the reference ranges. So on etiology was hepatitis B, on ALBI, it was the grade 1. For BCLC was stage 0, and then the best supportive care was the reference for initial treatment. And it was noted that multidisciplinary management was an independent factor for OS, but also along with sex, the etiology, the ALBI grade, the BCLC, AFP level, and also the DCP level. And then also the initial treatment modality was also proven to be an independent factor for overall survival when being compared to the references. And we can see in here that this was in the sample that was unadjusted, and then on the multivariable adjusted, where mainly the only one that was different was the one of the etiology. And then this table, it describes the overall survival that was stratified specifically by treatment modality. Just because what I explained in the previous slide, the treatment was, kind of different in the multidisciplinary group based on the BCLC. So there was no difference in overall survival, which patients who received resection in the overall cohort, as well as in the matched cohort. So we can see this in here when we're evaluating the overall one versus the matched one. And then among the patients who received ablation, better overall survival was observed for patients who received multidisciplinary care in the overall cohort, but then not on the matched cohort. And then overall, for the patients who received TACE, better overall survival was observed for patients who received multidisciplinary care, both in the overall and the matched cohort. And then this table describes the overall survival when it was stratified by treatment modality between the patients who received the multidisciplinary care and the ones who didn't. So, oh, sorry, I'm in the wrong slide. So this table has the hazard ratio comparison between the multidisciplinary approach and the non-multidisciplinary management. So we can see that actually the association was consistent across most subgroups, but the association was stronger on these three, where we can see that was mainly the ALBI grade, the BCLC stage, and also the AFP levels. So in conclusion, just putting together all the information that we just described in the tables. So better overall survival rates were seen in the patients that were managed via multidisciplinary care. Those who received multidisciplinary management had different baseline characteristics, as I mentioned in the beginning, and when we compared them to those who did not. However, when the multidisciplinary management was an independent factor associated with the better survival, despite the multivariable adjustment. So at least that's something that continues to be reassuring that this model is very beneficial for our patients. Besides this, the benefit of multidisciplinary care in our cohort was greatest in patients with poor liver function, also intermediate or advanced BCLC or high AFPs, which just mainly highlights the fact that multidisciplinary care is beneficial for patients that are in complex situations. And this brings up then a lot of the conflicts, whether who should be referred or who should be not, and who, based on all the funding that would be needed and the coordination for these meetings. So that's just something to keep in mind. Sorry. And then we also saw that those receiving non-curative modalities, which were mainly TACE and what were described as others, were much higher in the multidisciplinary group versus the one that was not managed in a multidisciplinary fashion. And something that they bring up in the discussion, which I think is a very fair fact, is that sometimes patients that are referred to these meetings are the ones that have very complex care. They might not be able to get the standard of care that we would think for being curative, because those cases are sometimes just managed without a multidisciplinary approach by their primary hepatologist with the surgeons, as Dr. Eswaran mentioned earlier. And then one thing that I think is worth mentioning is that one of the strengths of the study is that it was a very large cohort. So that's something to keep in mind when compared to the other studies that I saw before. Besides some of them that were just outdated, but a lot of them, the sample was smaller. So besides this, we did notice a slight difference in treatment allocation between both of these groups. What they bring up in their discussion is that we need to keep in mind that this is a retrospective study, which is clearly a limitation, and that prospective studies would be more beneficial. And then they also brought the same thing from the previous slide, that they usually evaluate on those meetings the cases that are most complex. So the treatment allocation, it would be difficult to establish the cost of it in an objective matter.
And Lucia, I think that's a really important point. In that the more complex the patient is, BCLC B and C, there's a real value to discussing in a multidisciplinary fashion, because BCLC criteria is not black and white, and there's a lot of variation and wiggle room between B and C. For someone that has a large tumor burden in the liver, but and a portal vein thrombosis is technically a BCLC-C, but I think we would all consider liver-directed therapy in that patient. And so having these complex conversation within the group to understand that, yeah, it's a BCLC-C, but we might offer out of standard of care treatment paradigm, I think is highlighted in this article, and that the patients that are brought to multidisciplinary meeting had a lower rate of following the BCLC criteria recommendations. Does that make sense? So I think, and I assume that's true at the other institutions too, and that's why we talk about these for sure.
Yeah, I do think when I was reading the study, I thought like the main focus was the overall survival. But then when I was taking a look at all the details in terms of the treatment, I was like, okay, I mean, this to a certain degree at first glance, you say like, this doesn't make much sense. But then when you think about the patient complexity and their staging and everything, then you realize that it's just very difficult to stay within what we call guideline medical therapy.
Sheila, we published something a while ago last year that showed that we deviated from the guideline initial recommendation over 75% of the time.
Yeah. I think it's important for all the members of the team to understand that, for sure. And there's also stage migration too. So if someone responds or doesn't respond and they move over to the left or right, then you have to reassess.
Yeah.
Lucia, a couple of comments. That's an excellent presentation. I think these multidisciplinary conferences or groups they require a tremendous investment from the players involved. I mean, probably all of us, ours is at 7 a.m. on Fridays, which is for me a personally terrible time to have it, but it's the only time we can get our group together. And we find, intuitively there's tremendous value from that group, but I think it's important to also honor the commitment. And we struggle with a continuous creep. There's an effort or a temptation to put patients that maybe aren't pertinent to the whole group into that conference list. You mentioned early in this presentation that maximum of 15 patients. I think parameters like that, these should be, at least in our view, tumor patients that have some decision-making that's pertinent to med-onc, rad-onc, IR, hepatology. You start to flood that list with additional patients, and it becomes cumbersome, unwieldy, and you lose interest from the primary players that you want involved. So I think that takes continued vigilance to keep that list pared down to the pertinent patients that benefit most from this multidisciplinary concept.
Yeah, and I think that's highlighted in this article, where the patients that had the greatest benefit were Bs and Cs, and we know that those are the most complex. As are easy, transplant or resection, and then we have all the non-HCC benign liver lesions and portal hypertension cases that we all get through also, which take an hour and a half. If we have an hour allocated, and it spills always into an hour and a half to hour and 45 minutes. And the last people standing are the suckers, I guess.
Very true. Yeah.
Yeah, so actually bringing to that point, that was my next slide, that, this all and as a concept sounds very beneficial and everything, but it does have, its downfalls as well. So it's not free of cost, as I was saying earlier, for institutions that would need to put up funds to get all the specialties together. And then that also the cases per week are limited. So then it comes into a point that what will be prioritized, and then how would we prioritize them? Does each institution just establish like a formula or some, I don't know, like their own criteria to decide who will be presented into these cases and who will not? And then for the limitation of the study, there are actually several. So it's a retrospective study, as we were saying before. And then also they could have been a fact of selection bias, because the decision to present the patients on these meetings were mainly solely to one person, which was the provider in care of the patient initially. And then also something interesting is that the multidisciplinary management was not provided for every treatment among the patients that received multiple treatment for HCC. So I think the minimum was 1, and then the maximum was 4, and the median was 1.4 times. So that also limits, to which extent do we establish the validity of the results. And then also just the etiology of HCC, which we mentioned earlier, that in South Korea, hepatitis C is a major cause. And that's why they probably just divided it in hepatitis B and then other causes of HCC, which, as we know, in the United States right now, it's somewhat deviated from that. So just generalizing all these findings to other regions have a degree of uncertainty. So yeah, I guess that's all I have. Does anyone have any questions?
It was a great presentation, and it was great to hear from everybody. Just thinking about the challenges that we have, there were many that were brought up, and thinking about how we can look at this further to improve patient care, and inform providers in the field. It was mentioned, insurance causing a significant delay in care. I was wondering if maybe we could look at that somehow across the Chicagoland in the different institutions, and work together to try to capture how often that happens for our patients. It will be increasingly hard with the lack of resources, but maybe I can send some ideas out to the group, or if anybody has thoughts about how we could capture that at the individual institutions and then pool our data. Or look at possibly the resources that are required at each institution, and think about working together to describe the experiences that we have in this challenge, trying to provide multidisciplinary care, including time, navigation, insurance issues. Like Mark was saying, using we all have a 7 o'clock Friday morning at 7 o'clock meeting, and it's just there's so many challenges related to this paradigm. So in all the research and data that's being done about multidisciplinary tumor boards, I haven't seen that much about all the challenges, and you only see the positive things, improved overall survival, as if it's so easy. So it's nice to hear that the other institutions, at least here in Chicago, have the same challenges that we do.
Yeah, Sheila, in my dream world, there's no 7 a.m. meetings on Mondays or Fridays, but of course I have 7 a.m. meetings on all Mondays and Fridays. I've heard the paradigm that once you get this kind of clinic or conference set up and running, you can even use it as an outreach tool. Have your satellite referring hospitals now virtually phone in, they preload the CTs, you can review their cases and decide how to adjudicate the treatment of their patients. Again, a tremendous amount of work. Logistically, you have all the clinical specialists present in a room for an hour and a half, and you can make decisions if you have all the clinical data points available. But then the background, insurance approval, regulatory issues, gathering the CDs, getting them uploaded into your PACS system, it's a huge lift, tremendous benefit to the patients if they can do that one-stop shopping rather than the linear kind of paradigm where they go from specialist to specialist. But I think this presentation by Lucia and this paper, it kind of adds proof to what we all think, that there's value in that organized evaluation with all the key players present at the at the same time.
Yeah, and you would think that the institution would then have buy-in if you present it in a way that it will increase referrals and then revenue. But I'm not sure that they see that downstream effect always. And we, at least at Rush, don't have a dedicated navigator for HCC, like an RN or a nurse practitioner, an advanced practitioner. And I don't think you guys do it at Loyola. You might at Hines. And I think Riyadh jumped off. So I'm not sure about the other institutions, but yeah, the amount of work that goes into it for someone that's not only can manage all of those things, but also has the clinical background, I think is so important too, to know what the important information is to gather even.
Yeah, and you would like to think, papers like this would support the idea that payers would get on board with the paradigm, that this is the route patients should be going because the outcomes are better, the care is quicker, you have more quality outcomes.
And patient satisfaction too.
Yeah.
Lucia, great job. Any other comments from the group? All right, have a great night. Thanks for your time.